Okay. Good morning, everybody. We are continuing the course of lectures organized with the support of Fund of the President of Ukraine for Education, Science and Sports. And this lecture will be recorded. Tell me, please, if it's okay for everyone and if nobody mind. Okay, thank you. Hope it's okay. Then we'll proceed. And today is our second lecture. And for the welcoming word, I'm giving the floor to Rector of Buchanan State Medical University, Professor Igor Gerush. Professor Gerush, the floor is yours.
Thank you, Ruslan. Dear colleagues, distinguished guests, dear students, it's my great pleasure to welcome you to today's lecture, which continues our international academic series implemented with the support of the Fund of the President of Ukraine for Education, Science and Sport. We honored to host Professor Devід Джейн and Mr. Pатрік Коклін from the University of Leeds. Today's lecture dedicated a novel imagining modalities in arterial disease reflects the growing importance of innovation and interdisciplinarity approaches in contemporary medicine, particularly in the field of vascular pathology, which remains a major global health challenge. I would like to especially note that Mr. Pатрік Коклін is a long-standing partner of our university. He has already visited Medical University twice, and we had the privilege to work together with the project Improving Care of Victims of Lower Limb Trauma in Ukraine. This collaboration has become an important example of effective international partnerships in support of Ukraine. We highly value this ongoing cooperation and are grateful for the willingness of our distinguished colleagues to share their expertise and experience with our community. I am confident that today's lecture will be both thankful and inspiring for all participants. I wish everyone a productive and engaging session.
Thank you very much. And I would also like to welcome for the introduction of the speaker, Professor Devід Джейн, with whose support this course of lecture is organized between our two universities. And using this opportunity, I would like to thank to Professor Jane for organizing this course of lecture and University of Leeds for our partnership and that grows and continues. Professor Jane, the floor is yours.
Thank you very much. It's a great pleasure to be part of this excellent lecture series, and I think it's a real celebration of the collaboration between our two institutions. This is the second in a series of 5 lectures, and my colleague Pàtrīk Koklīn is going to present to you on an area of his expertise, which I'm very much looking forward to hearing about, and that's on novel imaging modalities in arterial disease. So, Paddy, over to you.
Thanks, David.
Please.
Thanks, Ruslan. Thanks, Rector. And it's lovely to see so many friendly faces on this meeting. I just checked that you can hear me okay.
Yeah.
That's super. And so what I'm going to talk about today is some work that really I've been interested in for over a decade now. which is looking at different ways that we can image arteries and using some novel mechanisms that perhaps elucidate more information than we get from our basic imaging. So cardiovascular disease is common. We know that. We see it every day in our clinical practice. And when people talk about cardiovascular disease, they often just think about coronary disease, heart attacks, etc., or cerebrovascular disease, which is causing strokes. But I'm a vascular surgeon, and the vast majority of my work is looking at patients who have lower limb peripheral arterial disease or atherosclerosis. And what we're seeing now really is an epidemic of patients who are presenting with severe chronic limb-threatening ischemia, be that with gangrene to their legs or with non-healing ulceration, usually in the context of diabetes. And certainly 80% probably of our workload is related to trying to manage these patients. And here is an MRI scan that shows really a patient with extensive atherosclerotic disease. This is the infrarenal aorta, the aortic bifurcation that should then extend into the iliac arteries, level of the groin here, extensive disease in the femoral artery, and these are the crural arteries here that are very difficult to see. So this is a patient here who's got really extensive low limb atherosclerosis. And traditionally, this has been predominantly a condition of men with of older men, with 20% of men over the age of 60 felt to have some level of lower limb atherosclerosis. And why is this important? Well, we know that patients with lower limb peripheral arterial disease will also have arterial disease in other vascular beds. And therefore, this cohort of patients with lower limb arterial disease have significantly high risk of coronary disease and cerebrovascular disease. So they have 3 to 5 times increased risk of heart attacks and strokes. But also, unfortunately, this is a common finding that we get in our patients, is that they have an increased risk of lower limb amputation.
Я вже забула, як я це робила, і треба трошки якось
Lesa Lavriv, I'm very sorry. Lesa Lavriv, please turn off your microphone. Thank you.
And you can see here, this patient has already had a baloney amputation on one side and has got significant gangrene to the toes of the right foot. So here we know that it's common. It affects 20% of the population over 55 years of age. Diabetes has had a significant impact upon the prevalence of disease and also the anatomical distribution of the atherosclerosis that we see. In the UK, arterial disease alongside diabetes is a leading cause of major limb amputation. And for us in a public healthcare system, it aligns to significant costs. This is something that is commonly seen in Ukraine. I've seen this myself on the wards as I've gone around the hospitals in Chernivtsi. But for us, we undertake about 6,000 major lower amputations a year, and primarily related to diabetes and arterial disease. And we undertake a significant number of lower limb revascularizations, either through surgical bypass or using an increasing number of different minimally invasive or endovascular techniques. But what of imaging? So traditionally, imaging has been used to determine anatomical extent of disease. So for us within the lower limb arterial tree, we use it to look at the extent, the severity and the anatomical site of the atherosclerotic disease, the stenotic or occlusive disease that we see, to allow us to determine an optimal revascularization strategy in our patients. But the question really is whether the imaging that we use already, or whether there is new modes of imaging, can actually be a bit more predictive or give us some more information with regard to the overall outcome of the patients. So can we use the imaging to tell us which patients have increased risk of overall cardiovascular events, heart attack, stroke, or cardiovascular death? And then can we use the imaging perhaps to try and help us determine what revascularization strategies or what adjuncts to revascularization would lead to more success? And that's really going to be the crux of the rest of my talk. And when we talk about conventional imaging, we really talk about X-rays, ultrasound, CT scans, or MRI scans. They provide the anatomy of a problem, size, shape, and location. But there are other imaging modalities that we can use, and increasingly molecular imaging is having an increased role to play, primarily within oncology and the management of cancer patients. You can see here an example of a patient with prostate cancer, where the cross-sectional CT scan essentially shows a relatively tiny lymph node that appears normal in anatomy. But when you undertake the molecular imaging, this little lymph node is shown as a hot spot, and a biopsy was proven that this is spread from the prostate cancer to this lymph node here. And that has a significant effect on changing the overall treatment strategy for this patient. So in the first part of the talk, I'm going to talk about more conventional imaging in vascular surgery. And traditionally, we would use ultrasound or duplex, which is a combination of ultrasound and Doppler, MRI scans, or CT scans. If we see a patient with suspected arterial disease, this is sort of the pathway, the assessment pathway that we would use. We would assess them clinically with history and examination. We would undertake some non-invasive hemodynamic studies, which is usually the ankle brachial pressure index. If we felt that vascular disease was likely based on those initial investigations, we would then proceed to some sort of imaging, which would then allow us to determine the optimal treatment for this patient. So within this process, there's a lots of modalities that we can use perhaps to investigate to see whether these can predict poor outcome in patients. And for an example, this is using the ankle brachial pressure index. So this is where we take a blood pressure from the ankle and compare it to the blood pressure from the arm to give us a ratio of how good or poor the perfusion is to the foot. The lower the ratio means the more severe the atherosclerotic disease is. And you can see as the atherosclerotic disease increases, the mortality risk of patients also increases. So we already know that worsening atherosclerosis as a whole perhaps leads to an increased risk of long-term mortality. And here is an ankle brachial pressure index being taken. You can see the blood pressure cuff around just above the ankle. And this is a handheld Doppler that is seated, that is over the posterior tibial artery at the ankle, that allows us to find a closing pressure very similar to taking a blood pressure from the arm. But the ankle brachial pressure index is really a rather crude marker of overall limb perfusion. It doesn't really give us the detail from the point of view of the site or severity of the disease that we're seeing. And we are increasing our use of non-invasive imaging, predominantly duplex or ultrasound scans that give us an increased amount of information. So the question really was, does the information we gain from the imaging enhance our ability to predict outcomes in patients from the point of view of mortality and cardiovascular disease? And we looked at two aspects. We looked at the atherosclerotic disease, looking at overall burden and distribution. And then we looked at the role of arterial calcification, so the calcification that sits within the arterial wall. I'm going to show you a couple of studies that we've undertaken that reflect this piece of work. Before I do, as I said, we're increasingly using ultrasound as a method of assessing the anatomy, the site and severity of atherosclerosis within the lower limb arteries. It's portable, it's cheap, it uses no radiation, but it is user dependent and is time consuming. And so there are pros and cons with using this, but it is becoming increasingly the first line imaging modality that we use in vascular surgery. And increasingly, there are scores that are now validated that allow us to accurately predict or accurately score the site and severity of atherosclerotic disease. So it's an anatomic staging. And we use the Bollinger score, which has been well validated. And this really looks at the extent of the disease within multiple beds. So we would traditionally score the disease in the aorto-iliac segments, which is essentially the infrarenal aorta and the iliac arteries. We would then score it in the femoral-popliteal segments, which is the femoral artery down to the popliteal artery. So that's essentially the vessels that run through the thigh. And then we would score it for the three infrapopliteal vessels, the anterior tibial artery, posterior tibial artery, and perineal artery that sit within the calf. So we would look at the vessels within the pelvis, vessels within the thigh, and then vessels within the calf. And it would provide us with an overall score based upon the site and severity of the disease. So this was a study that we did when I was in Cambridge, published in the European Journal of Vascular and Endovascular Surgery. We undertook a retrospective review of a consecutive series of patients who had undergone a lower limb arterial ultrasound. We had a series of exclusion criteria, and each of the scans were then scored for their anatomical severity using the Bollinger score. We had a primary outcome measure of all-cause mortality and a secondary outcome of occurrence of a new cardiac or cerebrovascular event. So we would call this a major adverse cardiovascular event, or MACE. And we followed up the scans up to 2016. So we looked at 1,000 patients who had undergone a lower limb arterial ultrasound scan over almost a 2-year period. And we essentially, with a series of exclusions, ended up with just under 700 patients that we analysed. The median age was 74 years, with 60% of them men. It's reasonably consistent from the point of view of what we would see from an atherosclerotic, a population of patients with lower limb arterial disease. We followed them up for in excess of 5 years, and the primary outcome, which was all-cause mortality, at just over 5 years was 45%. That's quite significant. And those sort of mortality rates are in keeping with what one would see with some of the more severe cancer outcomes. So I think the first thing to take away from this is that lower limb arterial disease carries with it a significant mortality rate in the longer term. And that is one of the things that we need to try and address. When we looked at predictors for all-cause mortality, there were ones that one would expect from the point of view of age, history of cardiac disease, renal disease. But also what we found was that the extent and severity of your lower limb atherosclerosis was a predictor for all-cause mortality. And interestingly, if you were on the right medication, so if you were taking a statin or whether you were on an antiplatelet therapy, this was predictive. So again, it reflects the need to make sure that all our patients are on the appropriate medical therapy. But the take home from this, based upon the study that we did, was that patients who have more severe lower limb atherosclerotic disease had a higher risk of all-cause mortality. And this is just reflected here in these Kaplan-Meier curves. This is the total Bollinger score, the score just reflected in the femoral popliteal segments and in the crural segments. But you can see that those who have the more severe score, which is the green lines across the board, have increased mortality risk over time. So then we went on to look at using, again, just our standard scans that we use on a day-to-day routine practice to look at arterial calcification. There's increasing evidence that shows that, and I'll come on to this later in the talk, that arterial calcification is an active rather than a passive process and reflects an underlying inflammatory process within the arteries. It's well known within coronary disease that, and there's lots of information and lots of data out there around the ability for coronary artery calcification to risk stratify patients, but there's limited data in the lower limb arterial disease cohort. So in this study published in 2017, we looked at 220 consecutive patients who'd had CT lower limb angiograms for symptomatic lower limb peripheral arterial disease with a 4-year follow-up. And again, we scored their CT angiogram using the Bollinger score to look at the anatomy or the severity of the atherosclerotic disease. But we also used the Agaston score, which is a well-validated score for arterial calcification, to score the severity of calcification within the arteries in the lower limb arterial tree. A slightly different primary outcome, which was a combined cardiac mortality and morbidity, so very much focusing on cardiac outcomes here, with a secondary outcome of all-cause mortality. You can see here the CT scans, you can see here the aorta here with a significant rim of calcification within the arterial wall. And this is the superficial femoral artery in both thighs. And again, you can see here quite significant calcification. So that was the sort of thing that we were looking at from the point of view of this study. Our reliability score, so intra-observer reliability scores were strong, and there was really quite significant correlation between atherosclerosis and calcium, which one would expect and has been seen in studies within the coronary arteries as well. Over the course within this cohort, there were 32 patients who had a primary outcome, which is a mixture of fatal and non-fatal cardiac events. And when we looked at the primary outcome, those patients who had a primary outcome or who had suffered from a cardiac event had a significantly higher calcium score, 6831 here, than those who did not have a primary outcome. And a similar finding was found from the secondary outcome of all-cause mortality. So those patients who had poor outcomes had significantly higher arterial calcification. And when we split the cohort into quartiles, so this is 4 equal groups from minimal calcification all the way through to severe calcification, so working across the top of the table here, you can see that virtually all the cardiovascular events and mortality events occurred in that final quartile of patients who had significant lower limb arterial calcification. And there is really a little bit of a link within here, as this cohort probably also has higher ischemic heart disease, hypertension, diabetes, and a degree of chronic kidney disease. So this is all really interlinked. So I'm going to move on now to that's some work that we did look using sort of what I would call standard imaging techniques. I'm going to now move on to some more novel ways that we can look at arteries. This is the sort of the way that arterial disease develops over time, going from a normal vessel at birth, to developing sort of a fatty streak, and then progressive plaque development with a sort of strong lipid core that eventually leads to plaque rupture and thrombosis on top of that plaque, which leads to coronary disease, cerebral vascular disease, etc. And a similar process happens when you look at the effect of treatment. So increasingly, we are using balloons and stents to open up blood vessels within coronary disease, cerebrovascular disease, and lower limb arterial disease. And you get the balloon treatment to open up a vessel, But ultimately, you then get an inflammatory process that leads to restenosis. And in the lower limb arterial disease, we know that 50% of our treatments in the femoral artery, so if we balloon open a narrowing in a femoral artery, at 2 years, 50% of those will have re-narrowed off or occluded. So it's a fairly major problem in treating our patients and maintaining the success of our treatments. So atherosclerosis is an inflammatory condition. And the key sort of protagonist in this is this high-risk atherosclerotic plaque. And the high-risk atherosclerotic plaque has a degree of instability to it, which means that there are risks of plaque rupture, development of clot within the lumen, within the arterial lumen, that then leads on to heart attacks, stroke. And in the lower limb arterial tree, then disease progression. And there are well known through imaging that's already undertaken that there are a number of sort of defining characteristics for a high-risk plaque. This includes a thin fibrous clap, a large necrotic core, a degree of hypoxia, but also inflammation and microcalcification. And these are the two aspects that I'm going to talk about now within the next 10 minutes or so. PET-CT imaging is not a new technique. It's been used in cancer biology for many years, but about 15 years ago, one of my collaborators called James Rudd, who heads up the molecular imaging unit in Cambridge, started to use these techniques to look at sort of chemical processes within the wall of the artery itself. To conduct a PET scan, you use a short-lived radioactive tracer isotope that's injected into the patient, usually through a sort of the venous circulation, a cannula in the arm. And each tracer atom has been chemically incorporated into a biologically active molecule. You then inject the tracer, you allow that to circulate, so you allow the active molecule to become to circulate through the circulation and become concentrated in the tissues of interest. And then you place the patient into an imaging scanner. As the radioisotope undergoes positron emission decay, it starts to emit the positron, which is an antiparticle of the electron with opposite charge. The positron travels in the tissue for a short distance, during which time it sort of loses its kinetic energy until it decelerates to a point where it can then interact with an electron. And this interaction with the electron sort of annihilates both the electron and the positron, and it produces a pair of photons that move in opposite direction. And these are the things that are detected by the PET scanner. So it then provides a signal based upon that reaction. So this provides the functional imaging, and then what you use is a CT scan that then allows you to align that functional imaging with the anatomy of where the functional imaging is happening. So that is the basis of what is a PET-CT scan. The most widely used tracer is 18F-FDG. It's widely used in a lot of cancer. And it essentially is used because macrophages take up glucose, and it's a glucose analog. And so it is probably the most common tracer that is used in PET-CT imaging. Within the arterial circulation, the initial work was done looking at coronary and carotid disease. And within the studies that have been done, that there is good evidence that shows that FDG uptake reflects macrophage infiltration in human carotid atheroma. There's further evidence that shows that increased carotid FDG uptake is an independent predictor of recurrent events after stroke. And it also predicts risk of cardiovascular events and their timings when you look at uptake of FDG within the arch of the aorta. Probably over the last 10 years, a second tracer has been used in the assessment of arterial biology. So 18F sodium fluoride was primarily a bone tracer that was used in prostate cancer to look at bone metastases. The mechanism by which it works is it absorbs to exposed hydroxyapatite, which is a key structural crystal that's deposited in the initial stages of vascular calcium formation. And you can see from the previous work that I showed that we do get quite significant calcification deposition within arteries. And we know that that is a predictor of poor outcome. So therefore, it was felt that this tracer might actually hold promise initially as a means of identifying problems within the coronary calcification. And the reason why it's useful in the coronary circulation is that FDG is actually, there's a significant uptake within the myocardial muscle. And therefore, FDG in the coronary circulation is not a great tracer. So this was really work to try and find an optimal tracer that could be used within the coronary calcification, within the coronary circulation. And this was a study that was done with some of our more recent collaborators from Cambridge and Edinburgh. And this was really the first study that was used to look at the role of 18F sodium fluoride within the coronary artery plaques. And they looked at both ruptured and high-risk coronary artery plaques. So took a cohort of patients who were having an acute MI or unstable angina, and they undertook a series of imaging modalities, including PET-CT. And this is a PET-CT scan from the coronary circulation. And essentially what you're seeing here is a high uptake of sodium fluoride tracer within the coronary with one of the coronary arteries. So this is a hot artery and correlates to an increased uptake of sodium, the radioisotope sodium fluoride tracer. And what they showed from this study was that those culprit lesions, so the lesions or the blockages, occlusions within the coronary arteries that were causing the reason for the heart attack or the unstable angina, those culprit arteries had significantly increased uptake of sodium fluoride than the non-culprit arteries, so the other arteries within the coronary circulation. So through this, they felt that sodium fluoride was a predictor or did show up those arteries that were causing problems from the point of view of the heart attack or unstable angina. So why is this relevant? And why do we look at sodium fluoride as a marker of microcalcification? Well, an unstable plaque is characterized by, as I've talked about already, an inflamed lipid core where you get cell death. So the inflammation and cell death is the driver of this atherosclerotic disease. And there's now evidence linking the macrophage activity, this necrosis, this cell death, to microcalcification. So this is a natural process that occurs related to that cell death. And we see it in tuberculosis. So you see the calcium that you see in the chest x-rays related to tuberculosis. And by eventually coalescing into a large block, the calcification effectively walls off this chronic inflammation and essentially acts as a stabilizing effect. So a lot of what we're seeing in that calcification in the artery is the response to a chronic inflammatory condition, where the body's response is to try and wall off that chronic inflammation. And we can see those on CT, and we've talked about the issues associated with arterial calcification already. However, sometimes the plaque may follow another course, and there's increasing data that supports the fact that the processes around that early microcalcification process so that response to the necrotic lipid core, may actually be maladaptive. So it might actually not follow this path, but it might follow another chemical path where the microcalcification affects the very fine fibrous cap that sits within a plaque and ultimately leads to plaque rupture and thrombosis. And the hypothesis is that the sodium fluoride highlights this high-risk stage of microcalcification. So from the point of view of peripheral arterial disease and imaging, the two real questions that we posed ourselves was around, can we use molecular imaging to help us with regard to disease progression, but also can we use it to predict which patients will have a successful revascularization and which patients would have an unsuccessful revascularization over time, with the aim that if we could identify those patients who we know are going to have a poor outcome from revascularization, then is there something else that we can do to try and adapt that biology within the arterial tree to try and help patients? So this was a study that we did a few years ago now. It used molecular imaging to look at the risk, to look at a cohort of patients who are having a balloon angioplasty in their femoral arteries, and to see whether molecular imaging could predict those patients who blocked off their artery or those patients who did not block off their artery after their balloon angioplasty. So this is a diagram to show exactly what we did. We recruited patients who had a narrowing within their femoral artery in the thigh. They underwent a series of imaging modalities. So they underwent a CT angiogram, they underwent an ultrasound scan, and then they underwent 2 PET scans, one with the FDG tracer and one with the sodium fluoride tracer. They then underwent their balloon treatment, their balloon angioplasty of their narrowing within the femoral artery. And then at 6 weeks, they underwent then a repeat CT scans, so repeat FDG scan for inflammation and a sodium fluoride scan for microcalcification. And then we followed them through for a year, and we undertook an ultrasound scan at 1 year to see what had happened to the artery that had been opened up. Had it narrowed off, had it blocked off, or was it still open? These are the baseline characteristics. So we took 40 patients, and of those 40 patients, 26 of them had no problems within the year after their treatment. So they had no further narrowing, no recurrent narrowing of the arteries that had ballooned open. But 14 patients did. So 14 patients did have either a re-narrowing or a re-blockage of the artery that had been treated with the balloon treatment. The characteristics of the patients are really in keeping with what one would find from the point of view of a cohort of patients with lower limb arterial disease. And there was no difference from the point of view of patient characteristics between the 26 patients who had no restenosis and the 14 patients who had a restenosis. And when we looked at our reliability of scoring the scans, there was no major issues from the point of view of inter-observer reliability. These are just some examples of the scans. So this is the CT scan. These are the PET scans that we take. The hotter the artery, the increased uptake of the tracer that we've used. And similar here, you can see this was the FDG scans, and these were the sodium fluoride scans. The results are very similar, and I'm going to concentrate on the sodium fluoride first. This is the microcalcification tracer. These are the baseline scans. So these are the results of the PET scan that was undertaken before the patient underwent a treatment. And these are the results of the 6-week scan. So these are the PET scans that were taken at 6 weeks after the balloon treatment. The blue circles are those 26 patients who had no problems in the year afterwards. So these are the patients that had no narrowings or blockages that came back after their balloon treatment. And these are the 14 patients who had a re-narrowing or blockage. And the key thing here is that those patients who had no re-narrowing, no restenosis or occlusion after their balloon treatment, both in the scans prior to their treatment and in the 6-week scan, had a significantly lower uptake of the tracer when compared to those patients who did have restenosis. So those patients who had restenosis had higher uptake, had higher microcalcification, both prior to and after the angioplasty. And a similar finding is seen when we look at FDG that looks at inflammation. So those patients who go on to have complications or fail treatment have a hotter artery, both from the point of view of increased microcalcification and increased inflammation. And you can see that when we did some further statistical analysis, that there was a definitive value that we could use for both the sodium fluoride and the FDG, that if you had a score in your artery greater than 1.98, so if your artery was hotter than, 1.98, that was definitely the cutoff at which you started to see problems from the point of view of complications after your treatment. This gives us a definitive answer to the fact that, yes, we can use molecular imaging to predict poor outcome in patients who are having treatments of their arteries. But obviously, PET-CT imaging is expensive. It comes with a significant exposure to radiation. And so really the questions is can we use similar sort of methodology to assess the molecular biology, but use it in different ways and assess the molecular biology in the arterial wall in different ways. So this is some work that was done by my PhD student, Mo Chowdhury, when he went to Harvard as part of his PhD. And he went to see Farouk Jaffer into his lab, where they're starting to use a technique called near-infrared fluorescence, which is often abbreviated to NIRF. And with this technology, it doesn't use radiation. It is an invasive technique, but they use a type of fluorescent that occurs in the near-infrared region of the electromagnetic spectrum, typically between 700 to 900 nanometers. And in simple terms, they use a tracer. In this case, it was indocyanin green, which is a fluorophore, which absorbs the light at one wavelength, but then it emits light at a longer wavelength in the near-infrared stage. And when Mo went over there, really, once he'd finished the work on the PET-CT imaging, to look at this technique as a sort of perhaps a different way of assessing molecular activity within the arterial wall. And he used an animal model, and the study that he undertook was to hypothesize whether a different type of balloon. So in the study that we did, we just used a plain balloon that had no drug therapy on it. But there is evidence that drug-coated balloons and the use of paclitaxel, which is an oncology treatment, essentially, and paclitaxel is increasingly used in clinical practice now. But he hypothesized that whether the use of a drug-coated balloon rather than a standard balloon would be able to suppress the inflammation that we've seen in human studies, but using it in an experimental model in rabbits. And so he used a atherosclerotic model in rabbits, and you compared a drug-coated balloon with a standard balloon or sham treatment, and used the aorta was treated with the balloon treatment, and then he used a serial NIRF investigations over a series of time points to assess the effect of the different treatment strategies on inflammation. And what he showed was that using the drug-coated balloon reduced inflammation and it reduced plaque burden when compared to the standard balloon or a sham treatment, which indicated that the drug-coated balloon was probably beneficial from an anti-atherosclerotic point of view. And certainly this technique is increasingly being used in an experimental way, but yet hasn't probably yet hit mainstream use on a day-to-day basis. But again, that is still an invasive technique. You have to access the artery to undertake these techniques, and that naturally comes with a risk if you're cannulating the femoral artery at the groin to be able to get into the coronary circulation. Now, one of the benefits with lower limb arterial disease is that the arteries of the leg are really quite accessible. The coronary from the point of view of imaging, the difficulty with the coronary arteries is that the sternum is in the way, and therefore it's difficult to really use ultrasound and those sort of techniques to look at the coronary arteries. So you either have to use cross-sectional techniques or you have to use invasive catheter-based techniques. Our most recent work that Mo's undertaken down in Cambridge is to adapt some cancer imaging work that looks at molecular biology into the lower limb arterial tree. And this is really quite new, and we haven't yet completed this. We haven't managed to get this published, but it really is sort of proof of concept work. So we're using photoacoustic imaging, and that's a biomedical sort of imaging technique that combines light and sound to produce images of structures inside the tissue. So it was used primarily to look at neovascularization and angiogenesis within tumor biology. But we've adapted this to use it to look at plaques within lower limb arterial trees. It works by, there are short pulses of laser light that are directed into the tissue, and then specific molecules, e.g. hemoglobin, absorb the light energy. This absorption causes a sort of tiny but rapid temperature rise, which leads to a degree of thermal expansion. And this thermal expansion generates an ultrasound wave, which is a sound wave, and these sound waves are then detected back, and we can use those to reconstruct an image. What are the advantages of using this technique? Well, it allows us to look slightly deeper into tissue than just purely optical methods, because sound travels well through tissue. It's non-invasive, and it's a safe technique because there's no radiation as well. And this is really quite early work that we've done, but it looks promising that photoacoustic imaging could be another method that we could use to look at the biology within atherosclerotic plaques within the lower limb arterial tree. I go back to some of the earlier slides. Medicine, surgery, and certainly vascular surgery is increasingly becoming an imaging heavy specialty. Within that, there are huge opportunities really for us to use radiomics. Radiomics where you can use a variety of different imaging methods that allow you to look at really the minutiae at a pixel level from the point of view of scans. And this gives you MRI scans, duplex scans, CT scans, and it gives you a huge amount of data really that allows you to elucidate perhaps what's happening at a molecular level within the arterial tree. As I said at the beginning, we often use our traditional scans for anatomy only, but there is the technologies that are now available mean that we can actually use those scans for a huge amount more to try and elucidate a little bit more as to what's happening in the wall of the artery. And this is some work that we've done again with James and collaborators in Cambridge, where we've used carotid CT scans to really provide a lot of information about the biology within the arterial wall, and we've been able to correlate the radiomic findings on CT with some of our PET-CT imaging. And I think this is an area that is really ripe for further investigation. And why is all this important? Well, I think in atherosclerosis, there is a real recognition of the benefit of medication. A lot of what we have focused on over the last few decades has been the surgery, the improvement of the blood flow, the revascularization, the balloons and the stents and all those sorts of things. But I think now there is a increasing recognition that the medicines probably have as much benefit, if not more benefit, in improving outcomes in patients. And I think where molecular imaging, radiomics, and all this fits in is trying to personalize the treatment strategies for patients. We know that there's good evidence now that robust management of abnormal lipids improves outcome in patients with atherosclerotic disease. There's increasing evidence around the role of anti-inflammatory medication. And we are currently undertaking a part of a multinational study looking at the effect of colchicine in patients with lower limb peripheral arterial disease. But in a sub-study and working with our collaborators in Edinburgh, we're actually taking a group of patients who are enrolled into this colchicine study, but we are doing some molecular imaging on them to try and look at the effect of colchicine on the metabolic effects or the underlying biology at the arterial wall. And there's increasing evidence of a number of other anti-inflammatory therapies that are available. So I think we are moving into an area where we can start to use imaging techniques and then more advanced imaging techniques to sort of personalize the treatment of patients with atherosclerotic disease. Very much like we do with oncology patients now, where part of the oncology MDT is really very much about using all the information available to personalize that treatment strategy from the point of view of radiotherapy, chemotherapy, and surgery. And I think that's where we need to get to from the point of view of managing patients with lower limb arterial disease. I shall stop there, Ruslan. Thank you very much.
Thank you very much, Mr. Coklin, for such beautiful and interesting lecture. And dear colleagues, maybe somebody wants to ask some questions, please. For now, until the audience is thinking, I have a question from general surgeons. I am a general surgeon, and we deal with such category of patients quite often, and mostly we deal with the consequences of peripheral arteries diseases, and we deal with trophic complications, trophic processes, and not always these patients are over the age of 60. Sometimes these are quite young patients of age of 40. And my question, could you please recommend us something, maybe on your opinion, we can do something that could improve the diagnosis until these patients are not coming to us with such kind of complications? Maybe you have some decisions in your clinics.
So I think in younger patients, one has to consider whether the diagnosis is truly atherosclerotic or not, or whether there's another inflammatory process that's going on. We see a cohort of young people that do present with severe lower limb ischemia, chronic lower limb ischemia, and those patients with Berger's disease, where they get, for whatever reason, that sort of severe inflammatory reaction in the arteries in the calf, in the crural vessels, which is often linked in younger men with smoking. And that's really very challenging because it's difficult to revascularize those. I think from the point of view of I think you're right. And one of the things that we have here in the UK is trying to get our patients that need to be seen by us to be seen quicker, if that makes sense. So getting them into our service quicker. And a lot of that is around education and education of doctors who work in the community to recognise the signs and symptoms of arterial disease. For us, vascular surgery is probably not taught as well as it was in the undergraduate curriculum, partly because there's so many competing things that need to be fitted into a undergraduate curriculum. And a lot of our doctors who now work in community or primary care have not really had much exposure to vascular surgery at all. Mm-hmm. And I think that is a worry and a concern as the effect of the diabetes epidemic that we're seeing continues to progress, because we're seeing lots of people who have got very poorly treated diabetes, undiagnosed diabetes, with severe sort of problems with trophic changes. And as I said at the beginning, our ward is probably 80% of patients who've got significant trophic changes in their feet. So I think it's about educating at a community level, be that doctors, nurses, podiatrists, that they need to get into the system quickly, that we can then revascularize them quickly.
Mm-hmm. Thank you. Thank you very much. Yes,
hi.
please. Please introduce yourself.
Hi, my name is Andrew. I'm a PhD student in the field of neurosurgery, and I have one question. What are you waiting in the next maybe 5 or 10 years in the novel imaging development? Maybe AI, maybe some machine learning or artificial intelligence will help to decide whether to choose simple CT or ultrasound, or whether to use PET-CT or other advanced technologies that you mentioned. Thank you.
Thank you very much.
So I think there's a number of points to that first question about the standard treatments, in as much as that a lot of it is the access to the treatment. And what we're interested in, and certainly in our most severe patients, is reducing the time that we can take from patient presentation to revascularization. So we want to choose sort of the more optimal method from the point of view of how can we get those patients through quicker. And a lot of it depends on the examination as to which first imaging that we would use purely from a treatment perspective. So we would often use duplex first. We would then, if the duplex suggested that we could go straight to an angioplasty, we would do that. If it looked like from the duplex and angioplasty wasn't suitable, we would get some cross-sectional imaging, which would probably be a CT angiogram. And that would allow us to plan what we do next from the point of view of whether they needed a surgical bypass. From the point of view of the new techniques, I think the issues at the minute is that the costs of the PET-CT are quite significant, and the evidence base is probably not as robust at the minute for its widespread use as it perhaps is in the oncology field. And I think there probably needs to be more evidence and some cost effectiveness data that shows the true benefit of molecular imaging or its widespread use in atherosclerotic disease in the UK. I think you're right. I think how we incorporate AI and the use of radiomics and all those sorts of things within our conventional imaging that we do will be the key for the next 5 to 10 years. And that is certainly some early work that is being undertaken within vascular surgery.
Thanks for the answer.
Thank you very much.
We have one more question.
Yes, please. Please
Hello.
introduce yourself.
Thank you very much for your wonderful lecture. I really learned very much about this, but I have a very important question about that. So he's talking about balloon angioplasty. So does the balloon angioplasty in modern innovation work with the vasospasm like coronary vasospasm and the prismatal angina? And what is the success if you examine in your career about this prismatal angina? So can you tell me about this more?
Sorry, I didn't quite catch that. Could you repeat the question for me? Sorry, I do.
Could you please come up closer and please introduce yourself and repeat the question?
Okay. Hi, I am Ashish Giri. I am fifth year student in Bukovina State Medical University. And my question is, does the modern innovation technique, like you talk about balloon angioplasty, does it work with the spasm, like prismatal angina? And what is the success rate if you have, like you are examining your career?
So the management of coronary disease versus lower limb arterial disease from the point of view of endovascular treatment is slightly different because the vessels are different. When we're dealing with lower limb arterial disease, the vessels tend to be bigger. The reason we're doing it is more from a perfusion point of view rather than from an acute thrombosis point of view. So these vessels are probably more calcified, they're bigger vessels, so the complications that you get are slightly different than you would get within a coronary circulation. Having said that, we know that a straightforward angioplasty in your femoral artery has a restenosis risk of about 2 years. So, and if you treat the smaller arteries in the calf, the infrapopliteal arteries, the tibial arteries in the calf, then the risk of restenosis is increased. So what we're looking to try and do, either through advancement in stent management, balloon management, or altering the vascular biology at the arterial wall, is trying to improve those outcomes, really. And I think this is where we're trying to get to. The main complications that we see from the point of view of balloon treatment within the lower limb arterial disease is dissections. So you may see an acute dissection, and that then may need a stent to be inserted to try and pin that dissection back. But that's probably the biggest intraoperative complication or intraprocedural complication that we would see in the lower limb arterial tree following angioplasty.
Okay, sir. Thank you very much.
Thank you very much.
We have one more question.
Please.
Hello, sir. This is me, Priyash. I'm a fifth year medical student, and I have a question about imaging. So, can we superimpose two images, like a still image from MRI, which has higher resolution, and some lower resolution, but a real-time image, like an ultrasound, to get a more real-time view?
It's not something that I know that has occurred, really, from the point of view of combining ultrasound, superimposing the images, but we certainly will use different types of modality to sort of answer. It's not uncommon for us to use two different types of modality to examine a patient and use bits from those to sort of work through what the best treatment option is. The fusion comes for us from the point of, as I said, we would use PET imaging as your molecular imaging, and then either MR or CT to act as your anatomical imaging, and those two images would be fused together. But we wouldn't routinely sort of fuse a CT and an MR, no.
Thank you.
Thank you very much.
We have one more question.
Please.
Hello, good morning. Thank you so much for your nice presentation. My name is
Please come up closer.
Okay, my name is Patel Sana Siraj. and I'm a fifth-year student from BSMU. I have one question that you mentioned about drug-coated balloon. So I want to know that nowadays in PAD patients, how it works, like what is the main role?
So from the point of view of drug-coated balloons, they've been quite controversial recently because, so I think there is evidence that they, as we've shown, there's biological evidence and there's sort of clinical evidence that the use of drug-coated balloons reduces that risk of restenosis, that risk of reocclusion, it improves the long-term success of treatments. Having said that, some of the meta-analysis work that's been done has suggested that there is a signal that if, from the point of view of the use of drug-coated balloons and an increased risk of mortality in the longer term. And so there's been quite a lot of debate as to why that might be, whether that is the potentially particles off the balloon that might be causing problems or the systemic absorption. But it's not something that's seen in the oncology world.
Excuse me, please, Ruslan, please turn off your microphone.
Вони фірмовий магазин.
So really,
там не тільки Чирокі, там всі, це філія від Львівської. Колись вони у Львові були прямо біля обласної лікарні.
Ruslan, please turn off your microphone. Ruslan, виключіть мікрофон, будь ласка. Thank you. Sorry.
No, it's okay. So the use of drug-coated balloons is probably for those patients with more severe limb ischemia where we know their life expectancy perhaps is slightly shorter. And so we would use it in those difficult to treat lesions where we know that that are probably maybe anatomically at a higher risk of restenosis. So we would probably use drug-coated balloons there. I mean, I showed that if we look at a cohort of patients with low limb arterial disease, that their 5-year survival is only about 50%. So we would certainly use drug-coated balloons now in patients who've got sort of severe vascular disease, chronic limb-threatening ischemia to try and get better clinical results. Whether we would use it in patients with claudication that we're treating, probably not at the minute.
Thank you very much. Thank you very much, Mr. Coklin, for such beautiful lecture and for such a great discussion. You see that we have a lot of people who joined to us, and among them there are not only students, there are also teachers of our university, practical doctors from different institutions across the Ukraine. So the announce of your lecture brought these people here, and I want to thank the audience for the activity and for the interest for joining. I also would like to thank Professor Devід Джейн for organization of this course of the lecture, and the Fund of the President of Ukraine for Education, Science and Sports for supporting this project and for this initiative, and the University of Leeds for giving us the opportunity to work together. Thank you very much.
Thank you, Ruslan, and hopefully we might get one or two vascular surgeons that are coming through from this.
There are some of general vascular surgeons present, so I may say as a general surgeon that this lecture was very interesting for me, not being a vascular surgeon. That's why I really appreciate that you presented this topic.
Thank you.
Okay, dear colleagues, thank you very much for joining, and we meet in a week with a new lecture.
Bye now.
Have a nice day and goodbye. Олександр Миколаївич, ви можете виключати трансляцію.
Thank you, bye.